Thanks for logging on to discuss surgical palliative care or primary palliative care. This is sort of the Cliff Notes version, thanks to Dr. Christine Toes, who sort of generated a lot of these. And this can be a difficult topic at times. It's usually not everyone's favorite conversation to have to start, but I think it's actually critical that not only are we good at it, but we initiate it. So thanks for coming on. And I know my fellow panelists are encourage palliative care, practice palliative care, and hopefully we can ease your discomfort and encourage you to do the same. So am I sharing my screen? Or, okay, I'm doing it. Sounds fine. Okay. Did I do it?
You're still in presenter mode, or we can see the notes.
Yeah, my whole thing is frozen, of course, even though we practiced it ad nauseum. Okay, very good. Here we go. So thanks to Dr. Kodadek for this awesome, not AI produced title, the fourth pillar of acute care surgery, palliative care. So there's 4 pillars, if you will, that we're going to discuss today. We're going to start off with family meetings, which I think is really what's going to kick off and make the rest of your palliative care successful. Then we're going to talk about the neurodevastated patient, the malignant bowel obstruction and how to manage that. And then finally, caring for the imminently dying patient. So I'm going to introduce Dr. Kodadek, who created our title. Awesome. She's an acute care surgeon at Yale, New Haven. She's an assistant professor in the Division of General Surgery, Trauma, and Surgical Critical Care. She's a member of the AAST, and she sits on 2 of the committees, one of which is palliative care, and the other is critical care. And she continues to contribute significantly to streamlining the way that we care for both of palliative as well as critical care patients. And her research does the same. She complements these conversations and these papers that she has written with research in similar areas. She'll start us off tonight discussing about how to manage and conduct a family meeting.
Great. Thank you, Dr. Lueckel. If I could ask you to stop screen sharing, and then I'll bring up my slides. Perfect. Okay. Wonderful. Thank you again for the opportunity to talk about the key components of the family meeting. I will acknowledge that the content for this particular talk is derived from the AAST Palliative Care Committee product, The Family Meeting, a primer for surgeons. This is one of our so-called one-pagers, which we're quite excited to be sharing with the larger AAST community. So thank you very much to the members of the Palliative Care Committee who were involved in developing the one-pager. As you will note, I have used content from that to help discuss this topic this evening. All right, so this is an overview of what we will discuss with respect to the family meeting. So before conducting a family meeting, it's important to define the purpose of why you're meeting, determine whether the patient has capacity to make medical decisions for themselves, or make the medical decision that's being considered, identify critical participants to participate in the family meeting, and have a pre-brief. We will then talk about what goes on during the meeting, including introducing participants, discussion, and outcomes, and then finally, what happens after the family meeting, the debrief. So thinking a little bit more then about what to do before a family meeting and how to prepare. So it's important to define the purpose of the meeting. Why is a family meeting being held, and what is the intent of doing so? The interdisciplinary team may need to provide information pertaining to the patient's acute illness, diagnosis, prognosis, particularly in the context of underlying function, cognition, and medical comorbidities. It's important to potentially understand what's going on in terms of the patient's health priorities, treatment preferences, including goals, values. And in other circumstances, perhaps establishing and addressing the overarching goals of care to ensure that the current care plan aligns with those goals. These a particular family meeting may address any of these purposes or all of them. It really depends on each individual patient, their family, their surrogate, and what's necessary. But these are probably the most common reasons why a family meeting would be called. It's important to understand the concept of capacity. Capacity is the patient's ability to participate in shared decision-making, and it's for a specific decision at a given time in the medical setting. Capacity is determined by physicians, and we'll go into the elements of that shortly here. Capacity is different from competence, which applies globally, is determined by legal proceedings, and is actually not determined by physicians. So again, when we're talking about medical decision-making in the healthcare setting, we use the word capacity to refer to a patient's ability to participate and make that decision. So these are the elements of capacity. And we like to talk about the cura mnemonic, which is a helpful way to remember the 4 elements that a patient would need to demonstrate to have capacity to make a particular decision. The patient needs to be able to communicate a choice, and typically this is a clear and consistent choice. The patient needs to understand the relevant information about the diagnosis and the proposed treatment choices. The patient ought to be able to reason and deliberate around the treatment choices and demonstrate an appreciation for the risks, benefits, and burdens of the treatment and the alternatives to treatment, including palliation of their symptoms or ongoing medical concerns. Before the family meeting, identifying critical participants and who should be present, who needs to be part of the discussion. The patient should absolutely participate in the family meeting if they are able to participate. And even if they do not have capacity but are awake and able to engage with members of the team, it's important to include the patient. Certainly in our ICU settings, many of our patients are unable to participate in these discussions if they're critically ill, intubated, otherwise unable to engage, in which case it may be appropriate to hold the family meeting in a separate meeting room, near the intensive care unit. The patient's surrogate, their healthcare power of attorney, whoever is making decisions on behalf of the patient should participate, as well as family members. And then representatives from the key clinical services should be engaged. Generally, the attending physician should be present. However, if a representative from the team is involved in the family meeting, the representative ought to understand the facts germane to the meeting and the clinical decision that's being considered. Having the bedside nurse at the family meeting is incredibly helpful, as they often provide important insight and help facilitate some of the discussion, and many times have understood some of the concerns that the family has brought to the bedside. Social work may be an important resource as well, and then offering spiritual support for their presence to be part of the family meeting is certainly critical. Generally offer this to the family ahead of time and have a chaplain or other spiritual advisor present if that's desired. Having a pre-brief prior to the family meeting is critical for the medical personnel involved. This should include defining roles and who will lead the meeting, agree on a purpose for the meeting in terms of what medical decisions are being discussed or considered, and perhaps most importantly, address any differences in opinion prior to the family meeting to ensure that there's a unified approach and the entire team has a similar mental model for what's being discussed and what needs to be considered moving forward, including prognosis, including treatment options, including any role for palliation for the particular patient being discussed at the family meeting. During the family meeting, again, various components to address, so we'll get into this. The family meeting should begin by having everyone sit down, make sure the space is quiet and appropriate to facilitate this type of meeting. If it's being held in the patient's room, have chairs, have the ability to sit down and ensure that everyone feels that there's time to discuss what may potentially be very difficult conversations. Introduce everyone, introduce the patient, introduce the participants who are present on behalf of the patient, and understand you, or ensure that you understand the relationship of each individual to the patient. Clarify, if necessary, who the surrogate or healthcare power of attorney might be, and who's the point person, so to speak, who's helping to communicate to other family members that perhaps aren't present there at the meeting. It's also certainly the case that you could consider getting family members who can't be present in person in the family meeting by Zoom. We've certainly adopted that, you know, given our more recent COVID times. I think that's a helpful way to include family members who may, you know, be out of state or can't be present. And finally, the care team participants should introduce themselves, their roles, their discipline, and how they're involved in the care of the patient. Many times our critically ill patients in the ICU have numerous consulting services, and having each physician or physician representative introduce themselves and explain how they're involved is critically important for the family and the surrogate to understand the whole picture of who's caring for the patient. The discussion may center on a number of different topics, and this really pertains to why the meeting is being held. So certainly discussing the purpose of the meeting, beginning by asking the patient and their participants what they would like to accomplish during the meeting. It's certainly critical to assess what the patient and family knows by asking an open-ended question, such as, what have you heard or what have you been told? And trying to level with the family, level with the surrogate, understand where they're coming from, and ensure that everyone has a shared understanding of the current situation. It's critical to establish a shared understanding such that the physician team may need to explain current diagnoses and prognoses if known. And by asking that first question, what have you been told? It may be clear that the family hasn't been told much or hasn't had a full understanding of what's brought the patient to their current circumstance. So ensuring that everyone has the same information and then beginning to discuss, you know, the treatment options and next steps is a good way to start. Ensuring time to understand the patient as a person. One way to do this may be to ask the family members, if they're speaking on behalf of the patient, you know, what's important to your loved one? Tell me about them. What would they say if they were sitting here? How would they want us to understand their priorities and their treatment goals at this point? Specifying components of the care plan is critical. And then summarizing the patient's values, preferences, priorities, and goals as you've understood them from the family or surrogate who's speaking on the patient's behalf. And this is the whole point of a family meeting as well, to ensure that the care plan being proposed by the treatment team aligns with the patient's goals, and using the opportunity to ensure that the patient's goals meet up with the proposed treatment plans is an important consideration. Exploring the patient's values and how they may influence future decision-making should also be considered. And at the end of any family meeting, providing a concrete follow-up plan, a summary, a overall recognition of what's important to the patient and how the medical team is going to ensure that the care provided aligns with what's most important to the patient. It may be necessary to discuss some specific outcomes, and with respect to goals of care, understanding what matters to the patient, the values, priorities, and interests of this particular patient may include any number of things. Focus on cure of all disease processes may be a very reasonable consideration in many circumstances. For others, perhaps focusing on longevity or reaching a particular milestone, even in the face of an incurable illness or an advanced malignancy, may be something that we can help our patient and their family achieve. For others, focusing on quality of life. And then for some patients, focusing entirely on comfort may be an appropriate option. And the family meeting should help ensure that the goals of care align with the care being provided. And this may result in some change in what type of care will be provided following the family meeting. To that end, understanding some specific orders for the patient should be discussed as appropriate or as clinically indicated. The patient's preferences for cardiac life support following cardiopulmonary arrest, so commonly referred to as the code status. Full code would include chest compressions, electrical defibrillation, intravenous medications, intubation, and mechanical ventilation. No code or allow natural death in the event of cardiac arrest would mean not using any of those types of interventions and allowing a natural death should the patient sustain a cardiopulmonary arrest. It's important to also recognize that we shouldn't split components of care in the event of cardiopulmonary arrest where it wouldn't make sense from a clinical utility standpoint. For example, if a patient undergoes cardiac arrest and is under no circumstance willing to undergo intubation and mechanical ventilation, it wouldn't be appropriate to do chest compressions for that patient since they would not be able to receive oxygenation to circulate with chest compressions. And explaining this to the family and explaining, why it would be not beneficial to the patient to undergo chest compressions without intubation in the event of cardiac arrest. And again, in understanding where the family's coming from with desire to avoid certain types of treatments or interventions can be helpful. Delineation of patients' preferences for support in the context of acute clinical deterioration exclusive of cardiopulmonary arrest. So in this circumstance, perhaps intubation and mechanical ventilation outside of cardiac arrest can be considered, and additional preferences with respect, again, to deterioration outside of arrest may include use of vasopressors, non-invasive ventilation therapies, or cardioversion. So it's important to think about those options and discuss those during the family meeting. Finally, after the meeting, the team should debrief. This should discuss outcomes of the meeting, assign tasks, including order entry, any new consultations, care coordination, and documenting what was discussed during the family meeting and who participated, scheduling an additional family meeting if appropriate, and then proceeding with the care plan that aligns with the patient's goals, values, and priorities as discussed and agreed upon during the meeting. Thank you for the opportunity to discuss the family meeting, and I look forward to hearing the remainder of the speakers.
Great, thank you so much. It was a great way to start. I think questions are going to go through the chat. I think I forgot to mention that in the beginning. So the questions, if there are any, can be entered into the chat, and in between each talk, we'll try to address the previous question. So if you have any for Dr. Kodadek, fire away. And while you're thinking of your questions, I will introduce our next speaker. So our next speaker is Dr. Allan Peetz. Dr. Peetz joins us from Vanderbilt today on a very special day, I'm told, the beginnings of the teenage years. He has a son or a daughter who's gonna
My oldest is turning 13 today, so
13 today. So thank you so much for,
because the party might accidentally
might spill over into our party. Okay. So Dr. Peetz completed his fellowship in surgical critical care at Brigham and Women's Hospital when it was still called Brigham and Women's. And while he was there, he also completed a fellowship in medical ethics at Harvard Medical School. He is going to speak to us today about the neurodevastated patient.
very much screen here. All right, do you see it? All right, thanks. This is actually a really good, glad that we went in the order that we did, because there's a lot of overlap with Dr. Kodadek's talk. So what I'm going to review is the primer that we put together for capacity assessments and the neurodevastated patient. As I was thinking about Dr. Kodadek's talk and her mention of capacity in the context of the family meeting, it's obviously applicable to the neurodevastated patient, but we use capacity assessments in lots of different ways, and sometimes in just in the just general surgery writ large. So before I start, I want to obviously thank everybody from the Palliative Care Committee who put all of their thoughts and input into this, and then specifically Dr. Atopes, who put together most of the primer here, and so. Sorry, can you hear me? All right. So with the to introduce the primer, want to start with the definitions of capacity, which sorry, hold on 1 second. There's something wrong with my screen here. Give me 1 second. Sorry for the technical issues.
We could see it. It was projecting.
It's going blank on my screen.
Oh, okay, okay.
There's
And Dr. Peetz, in case you need me to, I can share your screen. I can share your slides, and you can just tell me when to go on to the next one.
All right. Well, I think it's actually my computer here. Let me try this one more time. Yeah, I think it's just my computer. All right. You see the slide? Okay, slide with the primer. Okay, perfect. All right, I apologize for that. Okay, so this is the primer that we put together with the Palliative Care Committee, and it just gives an overview of the idea of capacity. I want to review the concept itself, and then how that's applicable in the clinical setting. So the definition of capacity is really the ability to understand relevant information and consider the outcomes. So, and it's specific to the time of the decision, the time of the actual decision, and the actual context. So capacity capacity for something one day might not be the same the next day, and we know that intuitively because sometimes clinical status changes. But I think it's worthwhile stating out loud, mostly because sometimes there's a tendency to say that a patient has capacity or doesn't have capacity, and then just kind of move forward with that presumption with kind of everyday patient care. And it really does need to be reassessed and context dependent. And it's important to determine capacity and understand its definition, and to kind of come back to these principles, because a patient who has capacity has not only can make their own decisions, but they're entitled to make their own decisions, and they're allowed to give their own consent. In some ways, we worded it this way in part because patients who have capacity are also entitled to decide to allow other people to consent for them, but that was probably an idiosyncratic point. The determinant of capacity is important because capacity assessments guide the ethical priorities that determine clinical care. So any patient who has capacity to make decisions, a patient with capacity, the ethical priorities are for the protecting and enhancing the autonomy of the patient. So what that means is that a patient who has capacity, the clinical priorities, the ethical priorities determining the clinical decision making are really determined by what the patient says is important to them, and that is what trumps all else, trumps everything else. In a patient without capacity, you can't really honor autonomy. There is surrogate decision making that can serve as a substitute and substituted judgment through surrogate decision making, but the priority is really based on a best interest standard. So really, it's a fancy way of saying it's your best guess based on clinical judgment and experience, and integrating your decisions based on relevant information for that patient. So Dr. Kodadek went over, and I learned this from her actually, so I want to put that a shout out. There are many ways to kind of remember the important components of capacity assessments, but as she mentioned, my favorite one now is the Cura mnemonic, which is you want in your assessment, you want to make sure that the patient can communicate a choice, understand the relevant information, reason and deliberate around the treatments, and then appreciate the risks, benefits, and burdens. Now, it's all like well and good. How that works out in the middle of the trauma bay or the emergency department or the critical care is really where the rubber meets the road. And so oftentimes this is where the art of medicine really comes out. So one of the important points that we wanted to drive home with this primer is that the responsibility of the clinical, the assessment of a patient's capacity is really the responsibility of the clinician. And the reason that that's important is because capacity is dependent on understanding the relevant information. The clinician who is the expert and has the expertise to provide the relevant details that would describe the risks and what the goals would be of a certain treatment, whether it be an operation or an ICU procedure or a course of care, really needs to be the clinician who really understands those things, rather than being delegated to a psychiatric service per se. Which is not to say that those aren't useful, and certainly there are situations where capacity assessments are difficult enough that it's useful to have additional help, but it's really ideally done by the clinician whose clinical expertise is relevant. So the steps in assessing patients' capacity is to go through the steps of making sure that the patient can actually communicate a decision and understand the information, reason through them, and then deliver their decision. So one of the ways that you do this is, sometimes you do this kind of intuitively, and oftentimes it's good enough, but in the patient who is neurodevastated or has cognitive or has injuries or has a clinical pathology that would affect their ability to do any of these things, it's really important to kind of drill down and ensure that the patient does understand and is reasoning through things and not just kind of going along with what is being proposed because we're asking it in a way that gives a certain answer. So one of the few things that will help ensure that that understanding and a reasoning and a true autonomous choice can be made in a patient with capacity are to drill down specifically after delivering information to make sure that there is an actual understanding. The understanding of the patient is indeed what is relevant and important from the clinical relevant factors. Now, certainly, if that can't happen, if that doesn't happen to in a way that the clinician feels actually does reflect understanding and reasoning through the relevant factors, then that patient doesn't have capacity, or the clinician should say that the patient doesn't have capacity, or that's a reason to add additional input from, say, psychiatric services who can sometimes help with capacity assessments. So again, the capacity may vary depending on the complexity of the decision, and it's important to understand that a decision, a patient can have capacity for, say, a simple decision or a simple procedure with low risk and benefit profile, such as like an arterial line, but not have capacity for something, say, more complicated, like a Whipple or a thoracotomy. It's important to realize that that can happen at the same time, and that capacity assessments should happen for each individual case. So we'll related to, but sometimes confused with, or sometimes coming up in the same kind of issues that go along with capacity or legal aspects. Capacity is not a legal definition. It's not something that can be defended by the courts. It's not a legal definition. But patients without capacity can sometimes have guardianship or conservatorship issues that where the courts can determine a representative for that patient and serve as surrogate decision makers. All of these conservatorships and guardianships are based on a best interest standard for again, for patients who don't have capacity, where autonomy isn't driving the ethical priorities. And lastly, the oftentimes interchange this capacity and competency. I think more important is understanding the concepts behind capacity, and rather than knowing that it's just not competency, but competency is technically a legal definition that is determined by a judge, and not a clinical definition. So again, the capacity is about determining a capacity and developing the skill of assessing capacity in patients is important for respecting patient decisions and encouraging patient participation in decision making, but also ensuring that patients who don't have capacity, whether through inability to communicate or understand, that when we recognize patients don't have capacity for a certain decision, that the priorities are then gauged by by the best interest standard. So obviously the informed consent is the embodiment of respecting patient autonomy, and patients with capacity are entitled to it can provide informed consent in order to ensure the patient's understanding. Some of that onus is, a lot of that onus is on ensuring that we're communicating effectively to the patients. So sometimes the patients don't understand clearly because we're not being clear. So in capacity, in assessing capacity, as well as in delivering informed consent, and sometimes these things go hand in hand, providing clear and comprehensive information and considering the context that could influence understanding are important to consider. So again, this is all about considering what the ethical priorities and protecting patient autonomy. So in summary, the capacity assessments in the neurodevastated patient, but in anyone who has deficits that might or clinical context that might influence or affect a patient's ability to understand relevant information and make decisions that are in their best interest, or is that the onus is on the clinician to be able to make that assessment and provide the clinical context and be able to contextualize the patient's understanding based on the relevant information. And this is all about enhancing our patients' involvement in their care, and then ensuring that what we're doing is consistent with what they would want, or is in their best interest. And that also, lastly, that in real life, assessing these patients' capacity is a real skill, and requires some ongoing education and recognizing how we can do it better, and pursuing professional education to encourage that. So that is the end of the slide. I added that last part, but I think I've been rambling on and I had the technical difficulties, so I will stop here and stop sharing. Sorry about that.
Thank you so much.
Yeah.
I appreciate that. I think this comes up often clinically, like so much, and it's so difficult to determine, especially when you have your own personal bias as to what you think the patient should say. And if they really understand and they're saying the opposite, it's like, oh, they don't have capacity. So it can get sticky. But thank you. So I'm going to introduce our next speaker, Dr. Stephanie Joyce, with a PH, the way that it should be. She joins us from Connecticut and Yale Medicine, where she's an assistant professor of surgery in the Division of Trauma and Surgical Critical Care. When I was preparing our mini intros, she won the award for the most travel during her education, though the other two traveled a fair bit for their educations as well. But she started in Florida, where she obtained 3 degrees, and then hopped over to Ireland, down to Texas, over to Colorado to complete medical and surgical training. So it was pretty impressive, but she has landed in the Northeast, and she will be talking to us about malignant bowel obstructions.
Thank you. All right, I'm going to share my screen. Let's see if I can do this correct. Nope. Here we go. I'm talking about malignant bowel obstruction today, and this is a really challenging disease process I think we all face, particularly if you are at a smaller community hospital. I'm in an academic healthcare system, but I'm in actually a small 200-bed hospital. So we don't have surgical oncologists and all that stuff. So whenever a patient comes in with a bowel obstruction and it's from diffuse metastatic disease, I'm the one who gets the phone call, or our team gets the phone call, and it can be incredibly challenging. So I think this is a great primer for not just surgeons in big academic centers, but really for surgeons in community settings and smaller hospitals, as a something you can refer to. So once again, this was derived from a one-pager, all thanks to Dr. Tubbs. She's amazing. So a brief outline of what we're going to talk about. What is a malignant SBO? Some etiologies and diagnosis. The overarching management themes. We're going to talk about both non-operative and operative management, and symptom management, which I think is really important. And you really have to kind of shift your gears from, this is a person who came with in an SBO, like, is it an adhesion, hernia? Like, how am I going to manage this with curative intent? And kind of shift your gears to more symptom control, which is really not what we do by nature. Like, we fix the problem, we're surgeons. And so this is a really challenging process. So we've all been called with this CT scan. You know, high-grade SBO, patient looks okay, and then they're like, by the way, they have, you know, history of ovarian cancer or colon cancer, and they're on chemotherapy, like they're on Folfox or something, and you're waiting for the bowel to perforate or something like that, and you're like, what do I do? So what is a malignant small bowel obstruction? And this is another great CT scan. You see the malignant ascites, you see the thickened small bowel, some dilation, some decompress, there's probably a little fecalization. So it is a mechanical or functional obstruction beyond the GI tract with evidence of obstruction on radiography. It's either due to intra-abdominal primary cancer that is incurable, or a non-intra-abdominal primary cancer. Who here has seen malignant melanoma present with peritoneal carcinomatosis? I have, and I think probably several people on this call have as well. So it's not just a GI cancer that can cause this. So this is not you alone. Like, you need to manage this with a team, and your team really should involve both oncology, and it really should involve palliative care, because when it's gotten to this extent, they really need to be having those ongoing discussions. And while we all think we're great at palliative care, and we all are, they have additional resources that they can bring to the table. And sometimes they need to hear it from someone else. They need to keep hearing it. I think sometimes the frustration, I don't know, we all have, but with oncology, like, they're like, no, we're just going to give them chemotherapy and it's going to be fine. And so we need to continue to have discussions with our team, which includes oncologists, about prognosis and clear expectations. So what are your primary therapeutic objectives? You want to relieve the symptoms. You want to ideally get them to resume their cancer treatment, whether it's their chemotherapy or radiation therapy. You want to get them back to where they were, and resume care, preferably in not the acute setting. So if they're on home hospice, getting them home so that they're not consistently vomiting and they have good hydration or pain control. Those are all objectives that you should have, which, like I said before, is very different from when you have someone who comes in with just a normal SBO related to adhesions. Large bowel obstructions are usually amenable to endoscopic or surgical interventions. So I think we've all done loop colostomies, stenting is big. So large bowel obstructions are usually a little bit easier to deal with, because we can intervene on those and actually get people better and out. Small bowel malignant bowel obstructions tend to be really difficult to manage. They're usually related to malignant carcinomatosis, ascites, and so there's not like a clear pinpoint area where you can kind of intervene on. It's usually diffuse. They come back, you get them out of the hospital, and they usually come back in a couple weeks anyway. It's really sad and disheartening, and so they're incredibly much more difficult to treat. All patients should undergo a CT scan with oral and IV contrast. You want to hydrate them and normalize their electrolytes as much as possible. And almost everybody will initially get NG tube decompression. In more advanced stages, if they have a palliative G tube, you can just place that to gravity for drainage purposes. So how do we treat their symptoms? And so there's medical management, which was kind of new to me recently. Like we didn't really do this much when I was in residency. There's always this traditional thinking, don't give opiates in a patient with a bowel obstruction, you'll slow them down. Opiates are totally appropriate in this setting. Okay, they have oncologic related pain. Please treat their pain. You can use glycopyrrolate for management of secretions. You can also use octreotide as another option. And Haldol or dexamethasone is really good for both nausea and vomiting. And the dexamethasone is, in theory, used to treat like bowel wall edema and swelling, and hope to get their GI tract moving better. You want to support these people nutritionally. TPN is appropriate if it's within their goals of care. And sometimes patients who do go home need to go to the infusion clinic or get supplemental hydration in order to keep up with their losses so that they're not coming back with recurrent renal failure. I put this in big, bold. Patients with inoperable malignant bowel obstruction are usually candidates for hospice care. And even though they're medically complex and surgically complex, they might have tubes, they might need TPN, they might need all these medications. This can usually be managed at home despite their medical complexity. So don't think that these patients cannot get home. They can, and the resources are there for them. Some surgical interventional options. So diverting lobostomy is always an option. Resection or bypass. Lysis of malignant adhesions, which I have not really done in a very, very long time. And I don't think it's standard of care now, but it is an option. Placement of a decompressive gastrostomy tube or jejunectomy tube. And working in partnership with your advanced GI colleagues for endoscopic stenting for, upper, so esophageal malignancies, it usually works pretty well. Duodenal and pancreatic cancers, you can stent the duodenum, and then obviously colon cancers. Of note, when patients get their diversion, especially if they have a really high grade bowel obstruction, they tend to get very sick afterwards. So just something to keep in mind. So your surgical options really come down to if they have a single site of obstruction, they need to have good functional status. If they don't have good functional status beforehand, you're not really going to improve their quality of life or their long-term outcomes by intervening on them, and you might actually increase or intensify their decompensation. And expect significant morbidity and mortality, even if the operation goes seamless and everything looks great when you're done. These are very sick patients, medically complex, and they can deteriorate very rapidly. So having a lot of these conversations before they get to that point is very helpful. Your ultimate goals, you really want to relieve the symptoms, not necessarily with curative intent. And so I'm going to say that again, not with curative intent. Like we cannot cure these people, but we can give them their quality of life back. And really, you have to communicate effectively with your multidisciplinary team. That's oncology, radiation oncology, palliative care. Continuously having conversations with them is really important, or else you're just going to stall and stagnate and really not get the care that these patients need. Provide clear and accurate expectations with an empathetic approach. Not saying, we're going to get you back to normal and you're going to be great and you're going to live forever. Like, no, like we can get you home with TPN. You're going to have a bag, you're going to have a tube, you might not be able to eat, you'll probably live on Ensure Clears, but if that's okay with you, we can do that. So that would be an accurate expectation. And obviously keeping the tone empathetic, but using clear words that people understand. Sometimes people get lost in all the medical terminology and they don't really understand why we're recommending what we recommend. And having patience with them. They're going through a really hard time when you're recommending an ostomy. Nobody wants a bag. So it might take them, they might refuse initially, but having gentle persistence is really important, and they will usually consent, and then thank you afterwards because they feel so much better. So I know that was a little quick, but I wanted to keep us on time. Thank you. And if you have any questions, you can put them in the chat.
Thank you, Dr. Joyce. That was great. It is such a tough problem as a surgeon because you just want to fix things, and that's not one you can fix. So thanks for discussing it. I'm looking in the chat and I'm not seeing anything, but I want to check in with Caitlin. Are we getting any questions that we should be addressing?
Nothing in the chat I'm seeing yet.
Okay, that's fine. Just wanted to be sure. I will introduce myself. I'm Steph Lueckel. I'm also a trauma and acute care surgeon. I'm at Rhode Island Hospital and Brown Medical School. What are you guys seeing? I have 2 presentations up. Oh. What do you guys see?
It's your
Google Slides right now.
Oh, that's not what I want. I have 3 screens in case somehow something goes wrong. Okay, let's see. There you go, right? All right. You see a full panel? Okay, great. I will also shout out Dr. Toes for all of her palliative care primers. My topic is withdrawal of life-sustaining treatment and care of the imminently dying patient, a primer for surgeons. Thanks for sticking around, and thanks to my panelists, especially Dr. Peetz, who's neglecting a 13-year-old birthday party. So thanks for hanging in there. So hopefully, the first 3 speakers have primed you for some primary surgical palliative care. I do think it's really important, and I think this little section will hopefully bring it to life in terms of what you're physically going to see and actually have to do. And this holds true. This is a surgeon's responsibility. And in 1988, the college put out the statement that, the tradition and heritage of surgery emphasize that the control of suffering is of equal importance to the cure of disease. And I know I feel pretty strongly about that. And I do feel that it's my responsibility for my patients. We have a unique relationship with the patients. We often meet them on their worst day. We haven't had months and weeks to come up with a care plan and bob and weave when things may not go the way that we want to. And I think it's a unique opportunity to then have to discuss such a difficult topic with them. But we're built for this on a lighter note. They've studied this one particular paper that's in the Royal College of Surgeons of England, not Ireland. Sorry, Dr. Joyce. But it says, of course, that surgeons compared to medical docs are more neurotic. That's actually no surprise. But that we also have a sense of duty and a tendency for compassion and trusting when compared to non-surgeons. And I think that really sets us up to be able to deliver this comfort-focused care, if you will. So I love this picture. This is the real Patch Adams, and you may have your personal beliefs about him as a person, but this picture sort of highlights, aligning the care that the patient wants, certainly at the end of the life. And this is, I don't know, they're in some noodles or something, and I guess this is what this patient wanted. And if you've seen the movie, it's obviously more dynamic, but that's actually Patch Adams, not Robin Williams, who played him. So anyway, at the end of life, you're trying to figure out, as you've shifted towards comfort, what those goals are. And sometimes the goal may still be prolonging life, right? It still may be that I want to stick around until my daughter can make it from California, or, what have you. And so the two are not mutually exclusive. If it's just comfort care, it can still be, you know, the prolongation of care. So you know, it's important to sort of put both of those in your head. And then, of course, as been mentioned in the 3 prior talks, there's always uncertainty, but you're trying to emphasize comfort as your focus. And so you want to have unlimited visitation, space in the room, chairs. I know some facilities have comfort carts. I think that's what they're called, you know, coffee and things like that. And I think that's really important. So this probably looks familiar to many of you. It's the emblem from the American College of Surgeons. And I love this omnibus per artem fidemque prodose. I think it's such an awesome quote, if you will, or mantra, that words really do matter. You know, this translates to serve all with skill and fidelity. And I think that doesn't get lost here when delivering primary palliative care. You want to be truthful, you want to be true to the patient and true to their wants and needs. And what you say can really impact that. We've talked about using common language, like I can relieve your pain or your obstruction with a bag. You might need a tube. You know, we've already sort of talked about that. One of my favorite lines I heard somebody say once is, "I'm going to send you home with steak and eggs in your vein," to help describe TPN. And I thought that was awesome. And, you know, it's the same here when a patient is at the end of life. You want to, you know, use terms like focusing on comfort. The goal is comfort, and try to avoid withdrawal of care because that can sort of be unsettling to families and patients. So what does this actually look like once the decision has been made to make a patient comfortable? What are you actually going to see in the patient, the physiology? So the patient will usually not want to eat or drink. That's pretty common. They can do one of the 2 extremes where they're incredibly sleepy or they're agitated, times confused. They can actually have seizures. Certainly if they are predisposed to seizures, they have a seizure disorder, that can certainly happen. They could be cold, they can be mottled. A lot of us have heard literally and figuratively the death rattle, which is something we'll talk about how to manage a little bit later. And when these things start to occur, you really want to have a plan in place, medications ordered, a warning to the family, so that it can be handled as quickly and as appropriately as possible. This last bullet here, PRN is no longer appropriate. And basically that means all orders should be placed and the nurse should be able to give them without the patient having to say, "Hey, I'm in pain. Hey, I have a death rattle." I mean, that's pretty impossible. So how do we do this? This is the QR code. I think Dr. Peetz was trying to put it for his. I don't know if it'll work through Zoom, but certainly worth a try. So the orders should be in, I mean, we use Epic, so the orders should be in Epic. The nurse should have at her or his disposal all the medications that they're going to need to make not only the patient comfortable, but also the appearance of the patient, you know, lots of secretions, etc., should really be controlled. Sitting the patient upright so that they're not drooling, etc., so that the family can spend time and not be concerned with appearance or perceived suffering. Compassionate extubation is a tough one sometimes for all involved. It's important to pre-medicate, to suction as best you can, because that's going to be one of the more difficult things to manage and for families to watch. Dyspnea is treated with opiates. Like Dr. Joyce was saying, you know, pain and malignant bowel obstructions can be treated with opiates, and this is a similar situation. And of course, as you're preparing for this, you want to turn off alarms, and certainly AICDs. I hope none of you have experienced that, but I have. A patient was pronounced dead, and then the AICD fired, and we were off to the races of confusion. So turn off alarms. Certainly, even in the room, you can turn off the monitor altogether. And as you're preparing to care for the patient, it's really important to prepare the family as well for what they're going to see, for what the physicians and nurses may do to comfort the patient. And of course, the physical changes that they may see. They may see a seizure, that the patient may hallucinate, and those are all things that can be expected at the end of life. It's important to demystify some things that people might anticipate or ask you about. At the same time, being respectful of any cultural or religious beliefs that the loved ones, family, friends, etc., may be anticipating. Even if the science or the medicine says otherwise, it's important to respect any beliefs of where the soul goes, etc. So this is obviously a painting of Thomas Aquinas. I think this is really interesting, and I love that Dr. Toves put it in her primer. And of course, I went down the rabbit hole of all of the doctrine. It's grounded in Christianity, so we can set that aside because I think the principle is still important. Thomas Aquinas wrote, or started to write, never finished, the Summa Theologica. He was a scholastic theologian. Is that how you say it? Theologian? Anyway, he wrote this doctrine, and the intent of the doctrine of the double effect actually came out of homicidal self-defense. Until I told you I went into a rabbit hole with this, and basically I'm gonna read it so that I don't screw it up. The principle was first applied to homicidal self-defense, where Aquinas states killing one's assailant is justified, provided one does not intend to kill him. And maybe in more medical terms, to administer opioid drugs to relieve the suffering of a terminally ill patient, foreseeing that the hastening of death will occur as a side effect. And I know that this comes up a lot, certainly for medical students, sometimes residents, and sometimes nursing, if they've never done this before, that, oh, I'm giving too much morphine. I've never given that much morphine. And I get it. I think we all understand it, but that was sort of the intent behind this double effect, that's okay, because the intent is not to harm, but to help. So this is a sort of a live shot of my personal primer. Mine was blue, which you can hopefully find with that QR code. And that is sort of the Cliff Notes, if you will. No one probably even has Cliff Notes anymore. But anyway, a really quick introduction as to what patients look like and how to prepare for them at the end of life when you know that they are going to pass. So thanks everybody for hanging in there. Thanks to our speakers. Thanks to Caitlin for sorting us out. Are there any questions in the chat? It looks like maybe there's one, but I don't.
Yes, there is one in the chat.
It's from Dr. Cooper. Everybody hunker down. What do you do when there's conflict in the family? Anybody want to take a stab at that one first? I can certainly try. I mean, we've all experienced this, right? I mean, the family very rarely agrees, certainly on that first family meeting. I personally keep coming back to what would the patient want? What would the patient want? And sometimes the first couple of times, really, it doesn't settle with the family. But I think as conversations go on and you keep trying to bring it back to what the patient would want, sometimes you can jog a family member to go, yeah, they probably wouldn't want this and I want this. But it takes families a while to get there. I think, like Dr. Kodadek said, it's really important to be sure know exactly who you're talking to, know who the stakeholders are in that family meeting, because there can be strong opinions, but ultimately it may come down to the spouse. And if the spouse is the one that's supposed to be making the decisions and they're really doing it in the best interest of their wife or husband, I think you can ultimately go with their decision. Does anyone else have another calming method?
I don't know that I have any wisdom or calming method. My approach to this, obviously, it's context dependent, and maybe Dr. Cooper has a specific case in mind, or like, but my approach to this has been to I used to immediately kind of fight it and try to resolve it right away. And over the years, I've stopped doing that, and not with the intent of like well, just like kind of giving up, but actually preparing, usually for giving some space to it and not fighting it, not providing any sort of like disagreement about it, but also not agreeing, but allowing some time for that conflict to just happen. Now, the fellows and myself, for honestly, it's like, how long are you going to let this happen? I don't know. I usually, but and that is its own problem, and I don't have an answer for that. But my approach usually is to let it be for a little while and to continue to inform them. And then there's also some kind of tricks about like I like Dr. Lueckel said, bringing it back to like what would the patient want. And I've learned a couple of tricks from the palliative, some excellent palliative care doctors that I work with, and then also some that I've still carried from Dr. Cooper, who taught them to me, of getting at like kind of focusing on the patient. But I guess that's my answer, is that I let it be for a little while and see if time will just kind of let it happen or resolve.
I try to get to what the family thinks the future is going to look like, because a lot of them look through this whole situation through rose-colored glasses, and they're like, they're going to go home and they're going to be walking around and they're going to go back to their garden. And I think once you kind of set up more realistic expectations of like, actually, no, your loved one's probably never going to go home again. They're going to wind up living in a skilled nursing facility. They're going to have tubes. They're going to, not have the life they had before this, and give them, once again, time and space. I usually find that can be more effective, because I don't know, when I come in, sometimes people don't tell them like, well, when they get the tracheostomy, like what that road looks like. And then if you tell them what the road looks like, actual realistic, people are like, oh, no, I don't want that. They wouldn't want that. And I think that's another kind of tool to keep in your belt of like, really, because people don't see the long term like we see it. And so you have to communicate that effectively.
Yeah, I think conflict is pretty normal in these situations because it's challenging and no one expects to find their loved one critically ill in an intensive care unit. And I think, whether it's adult children and a spouse or other family members, I feel like there's always some conflict because it's a really challenging situation. And I think that's a normal part of the process, and providing the family with resources to navigate those concerns. Again, focusing on what would the patient want, asking the family what they're worried about. Maybe the conflict exists because one family member thinks the loved one is suffering and others, don't see it as such. So sometimes understanding, what the concern or the worry is can help elucidate why there's conflict, and maybe we can offer some resolution to that concern. It looks like there's another question from the attendees. When do you decide about futility and not offering a procedure, even if the patient's family wants quote unquote everything done. This is an incredibly challenging scenario as well. I'll take a first attempt to address it. I think futility is a little bit of a dangerous concept. There was a great multidisciplinary collaborative approach to this concept of futility in a paper written a while back. I think it included SCCM and a variety of other groups that contributed to this idea. And futility should really be a fairly narrow type of definition, in that something is truly not physiologically possible to be futile. So if you have someone maxed out on 4 pressors and their MAP is 40, then it's physiologically not possible to obtain a better blood pressure. That is a futile situation with respect to the medical ability to improve that patient's physiologic blood pressure. But I think outside of a very narrow scope, there are a lot of potentially inappropriate interventions. Just because some intervention may not be futile by the very narrow definition that's been proposed by SCCM and others, something may still be potentially inappropriate because it may not benefit the patient. And I think I can assure you that certainly when we're caring for ill patients in the ICU, maybe who are facing the end of life, we are doing everything for those patients. We are caring for them. We are ensuring comfort. We are treating pain. And I still think of what we do at the end of life as doing everything possible to care for that patient. So, when we talk about interventions that aren't going to benefit the patient, we shouldn't offer those. We shouldn't do things that will not benefit the patient. And I think we simply have to ensure that how we communicate with the family reflects the fact that certain interventions are not going to be beneficial and therefore shouldn't be done. Maybe I'm not sure if that fully addresses the situation. I'd love to hear insight from the other speakers as to how they address the everything needs to be done situation.
I think one of the points that's already been made is sort of letting the dust settle, because I think, on day 1, 2, 3, that is almost always the do everything. It's so rare that in the first 12 hours a family says, no, we're going to stop, right? I mean, it's always, so I think letting the dust settle, like Dr. Joyce said, sort of painting that future picture, a reality, or the new reality, I guess I should say. I think it's a really difficult, specifically for surgeons, because I think a lot of us are wired to fix with instant gratification, and we want to feel like we're doing something in that moment, and it's really hard to pull back on that. I also think that there's on one shoulder the fear of being sued because you didn't do quote everything. I think a lot of people think that. I know I have colleagues who will literally operate and do everything until the bitter end. And I wonder if it's to make them feel comfortable that they did everything, because I think Dr. Kodadek is right. If it's really not going to help the patient, it really shouldn't be offered. And I think a lot of us are afraid to do that, myself included. I mean, it's sometimes really heartbreaking to look, certainly for me, at a younger patient, 26-year-old, and say, it's not going to help. This patient's going to die no matter what we do. It's difficult. But I agree with you about the narrow scope of futile. It is a really narrow definition. If you've ever, I don't know if any of you have had to get the ethics committee involved, but I mean, it is a very narrow definition with regards to futile.
Yeah, and certain states actually have laws, like in Texas, they, believe it or not, have a Medical Futility Act. So understanding your local laws is really important. But also sometimes they need to hear it from someone else. Like you have this relationship and like bringing someone in. So if I'm kind of having trouble, sometimes I grab my white-haired partner and I bring him in because there's something with the bow tie and the white hair that really makes people listen. Or offering a second opinion, things like that. Because sometimes you get so wrapped in with the relationship with the family, it's helpful to have someone else come in.
Should, Dr. Kodadek, do you want to read what you put in the chat, or do you think?
Oh, sure. This is the policy statement from SCCM in collaboration with a number of other groups about how we should define futility quite narrowly, and then this larger bucket of potentially inappropriate treatments. I found this article really helpful. So it may be helpful to some of you who are trying to navigate this area around, doing everything. I think it's still very difficult, and I think there are still many circumstances where a patient may have a small chance of benefiting from an intervention, and it's very reasonable to do that intervention, to offer the surgery, the treatment, if it may benefit the patient. In fact, you should probably, when you think about withdrawing or withholding treatment, so you almost need to have a stronger reason to withhold a treatment than to start a treatment and ultimately withdraw it, because you can always consider a time-limited trial. You can try something and see how it helps. I think about this more in the ICU with therapies like dialysis or other interventions where we can monitor the patient's response. But when it comes to surgery, it's a much more difficult situation because you potentially open up the opportunity for harm, for suffering, for a prolonged course with no potential benefit to the patient, and your outcomes may be no different. So, I think it is so difficult, but when there is a circumstance where the patient clearly would not benefit from a surgical intervention or would be harmed by such an intervention, I do think we have a duty to ensure that the patient and family understand, that we do not think this would be beneficial, and so it is not, something that would be offered. But it's tough, and I think for many circumstances, if there is even a small chance that we could benefit the patient, offering the operation with a full understanding that the patient may face a more difficult recovery, may face significant complications, and ensuring that you've addressed goals of care before proceeding with that type of operation is really important.